Go ahead, ma'am.
Good afternoon, everyone. Myself, Dr. Kanchan Durugkar. I am consultant at Oasis Fertility, Wakad, Pune. Today, we are here to discuss about newer recent advances in IVF treatments. First of all, I would like to discuss what is the routine IVF that we go ahead with, and what are the recent advances that have come up that we will discuss in our today's Facebook Live session. So, welcome, dear friends. So, in routine IVF, what we do generally is from the second day of whenever you are advised for the IVF for any reasons like repeated IVF failures is there, or if at all ovarian reserve is less, or if at all male factor is there like azoospermia or oligozoospermia is there, or any other factor like bilateral tubal block is there, or any other problems are there which for which IVF has been advised to you. So routinely what we do is from the second day we start the treatment. We give you some injectables in the form of gonadotropins. These are the injections which are used to stimulate the ovaries. Then we give you some other antagonist injections. We stimulate the ovary, we make the follicles, they grow in size. Then we give the trigger injection. Then we retrieve all these eggs under anesthesia. That is called as ovum pickup. Then after ovum pickup we do is either IVF or ICSI. ICSI is a recent advance that is called as intracytoplasmic sperm insemination, in which we inject the oocyte with the sperms under microscope by the injecting needle, that is called ICSI. Then after ICSI we do is the embryo culture, and according to clinic either we can go for fresh embryo transfer or frozen embryo transfer. So this is the routine IVF procedure that is followed, and this IVF procedure has more than 40 years have passed for this IVF procedure that is being followed. So earlier the trend was, like more of fresh embryo transfer. Transfer, I mean that the cycle in which the eggs are made, that is ovary is stimulated in that cycle when in which the ovum pickup has occurred. In that cycle itself, the embryo was transferred. So either it was transferred as a day 3 embryo, that is the embryo has development stage of that embryo is day 3, or it has developed up to day 5. So the day 5 embryo is called as a blastocyst. So earlier the trend was of fresh embryo transfer and not frozen embryo transfer, and more of day 3 embryo transfer. But with this day 3 and fresh embryo transfer, the success rate of IVF was little bit less. It was in a tune of around 40 to 50%. But with the recent advents like you know day 5 embryo transfer, there's a blastocyst culture. Now why this blastocyst culture was not there and now it has come up? So with the advents of recent lab modification or embryology lab advances, this is possible to grow the embryo in the lab till 5 days. Okay, 5 to 6 days we can grow the embryo in the embryology lab itself, and then we can freeze those embryo in the liquid nitrogen tanks. So this like liquid nitrogen tanks have the temperature of minus 197 degrees Celsius. So in this they are frozen. This is called as a frozen embryo, or this is called as a cryopreservation. Now why this cryopreservation come up, or why it was not that successful at that time? So earlier it was slow freezing, or the technique of this embryo freezing what was not that you know uh, was not that advanced, or was not that foolproof that embryo could have been frozen properly, and then when we thaw them, then the survival rate of these embryos was also poor. Now with the advent of new cryopreservation method, that is new freezing technologies that have come up, the day 5 or day 3 embryos that we make, they can be cryopreserved, they can be frozen, and then we can thaw them and do the embryo transfer that is called as a frozen embryo transfer. Now this frozen embryo transfer, the cryopreserved embryos, that is the frozen embryos that are thawed and they are transferred. Now there are various papers and number of papers are coming up. They are saying that the success rate of frozen embryo transfer is more as compared to fresh embryo transfer to the tune of 60 to 70%. And of course, if the embryo has grown in the embryology lab up to day 5, then it has a greater potential of giving us a pregnancy and a live birth rate. So the blastocyst culture that is we are doing and the frozen embryo transfer, these recent advances have given us a better successful pregnancy outcome and live birth rate. So this is the recent advance that is helping us in giving babies to the infertile couple. Now what is the recent advance in the patients with repeated pregnancy loss or in the patients with repeated implantation failure, I mean they have undergone repeated IVF cycles, also they have undergone repeated embryo transfers. Now in these patients, the other advances have come up in the form of PGTA or PGT according to the genetic abnormality PGTM or PGTSM. Now, what is PGTA? What is it? So, PGTA generally the embryo that we transfer is not of that potential to give us a clinical pregnancy and live birth rate, is what we think. So, if that embryo can be tested for any genetic abnormality, any problem, if there that is there in the embryo, if that can be checked, then the pregnancy rate and the live birth rate can be improved. So PGTA is one of the recent advance. Now what is done in PGTA? Generally we make 5 days of embryo, that is blastocyst I talked about, and we take the biopsy from this embryo, that is called as embryo biopsy. That is few cells, 7 to 8 cells from this embryo is taken and they are sent for checking to the embryology lab, and we see for any structural rearrangements, any monogenic disorder, or most commonly aneuploidy, that is called PGTA. So we can see for these various genetic abnormalities that are there in the embryo, and then if at all we get a abnormal embryo, we can keep them aside, and the euploid or the normal embryo that are there, we can go for their transfer. And yes, we can definitely improve the success rate in the patients with repeated implantation failure, repeat IVF failure, and also in the patients with repeated pregnancy loss. Yes, so this is the advance in the patients with repeated implantation failure and repeated pregnancy loss. Now coming to ovarian rejuvenation. Now dear friends, in ovarian rejuvenation, different experiments are happening, different positive result also we are getting, but yes, still it is a experimental therapies. I will first tell that before coming to what are the ovarian rejuvenation techniques that have come up. So these are actually the experimental therapies that have come up, but yes, it has shown promising results in many couples who actually don't want to opt for donor eggs. So, what are these ovarian rejuvenation techniques that have come up? So, these are in the form of ovarian PRP, where we inject the PRP, that is platelet rich plasma, in the ovarian stroma under anesthesia. This procedure is done, that is called ovarian PRP, or ovarian stem cell instillation can also be done, or ovarian tissue activation is also one of the ovarian rejuvenation technique, in which laparoscopically the ovarian tissue is teased, like ovarian tissue is taken, it is made into fragments and then it is again put back, that is called as a ovarian tissue activation. And yes, in India also the ovarian tissue activation has successfully given a spontaneous pregnancy to some couples. So these are all the ovarian rejuvenation techniques which are used in the patients with poor ovarian reserve or poor ovarian response, in whom their ovarian stimulation has failed, or they have failed to respond to IVF treatment. And this ovarian rejuvenation technique can help in the spontaneous pregnancy also, or to give a better outcome with IVF technique also. This is the treatment. These are the experimental treatment modalities for the patients with poor ovarian reserve. So this is about ovarian rejuvenation. Then coming to, what are the recent advance in the in the male infertility. So in male infertility routine treatment, actually, previously, the in the patients with azoospermia, or the male partner is having azoospermia, they were only left with the option of donor sperm. But it is not the case in the today's IVF practice. Even the patients with azoospermia, even the patients with a non-obstructive azoospermia, I will stress on, can have, the embryo or the baby of their own gamete. This is possible with the help of, micro tessay, that is the microscopic, assessment of the testes we do, and we see for the areas of testicular uh, spermatogenesis in the testis. We see under the microscope for the areas of spermatogenesis, and from there we extract the sperm. And even in the previous Facebook live also we have said about this, that there is a sperm AVD, that is sperm vitrification device has come up, in which we can even freeze, one or two sperms also we can freeze in that sperm vitrification device, and we can use them for ICSI. So these recent advances in the form of microscopic retrieval of sperms, I will say in the normal language, that microscopic, retrieval of the sperms, microtessay, and sperm AVD, that is the vitrification or freezing of single sperm, I will say, is possible with the recent advances that have come in the field of male infertility. So these are the different techniques which can give us pregnancy in the patients with azoospermia. Also, there are recent papers coming up about, testicular PRP in the patients with, testicular failure is there. Matlab, main problem is there at the level of testicular tissue, or there is a testicular atrophy in those patients where previous testicular extraction was failed. In those patients, testicular PRP is also tried, and papers are coming up where they are saying that they got a sperm retrieval, and they could get the pregnancy and live birth rate in those patients with non-obstructive azoospermia even. So this is again a recent breakthrough, we can say, in the patients with azoospermia, non-obstructive azoospermia, and obstructive azoospermia. Yes, there the treatment is possible. Also, the patients with hypogonadism, in these patients, even they can achieve a good sperm count with the help of hormone replacement therapy in the form of gonadotropins and some medications. These patients with hypogonadotropic hypogonadism can achieve, of course, the duration of the treatment in these patients is long, in the form of, 1.5 years to 2 years even. But these patients may have, a good outcome in the form of good sperm count, and good pregnancy rate after that. Now coming to IVM, this is also one of the promising techniques that is coming up in IVM. Now, what is IVM? Full form of IVM is in vitro maturation. What is in vitro maturation? In the actually it is, we are promoting it as a drug-free IVF. Now, what is it? Actually, in this we give some low dose of gonadotropin. We do not stimulate the ovary like we stimulate it in the routine IVF. We stimulate it in the form of milder form of stimulation we do, or we stimulate it in the low dose, and then we retrieve the eggs. We do the ovum pickup from these eggs, and then we keep them for maturation in the embryology lab. So we retrieve the eggs, we retrieve them in the immature form, okay, and we mature them in the embryology lab. So it is called as a in vitro. In vitro means it is the eggs are getting matured in our embryology lab. So this is also possible in the patients in whom the previously the IVF was failed, or who are afraid of this stimulation, ovarian stimulation, and so many injections. These those couples, or those ladies who are very much afraid of taking injections and having this ovarian stimulation, they can think about this IVM technique, which is also available with Oasis Fertility. Now coming to the very common uh, case that we come across when we are going through IVF, that is thin endometrium. So, in previous our Facebook lives also, our colleagues talked about it, that thin endometrium can be treated. It is not that the endometrium is thin, that means that, or there is some other endometrium related problem, that doesn't mean that you cannot conceive. There are recent advances that have come up in the form of hysteroscopic metroplasty, we can think, or adhesiolysis. If at all you intrauterine adhesions are there, if there are some adhesions inside your uterus, they can be cut. Then there can be, we can do is the hysteroscopic PRP, where we inject the platelet rich plasma in the uterus, in the endometrium layer, and this PRP has some growth factors, and it actually helps in growth of the endometrium. This is about the thin endometrium. There are other treatments about thin endometrium, I will not elaborate on it very much. Then coming to the endometrial receptivity testing, that is called ERA testing. ERA testing we can opt for in the patient with repeated implantation failure, in whom the grade of embryo or the quality of embryo was very good, and there was no other factor, no other significant factor for the IVF to fail. Embryo quality was also good. Then in these patients, ERA needs to be checked, because for in these patients, window of implantation may be shifted, and we need to check for the window of implantation, and personalized embryo transfer after ERA testing can help us in giving a better successful pregnancy outcome. So this is about ERA testing. There are other newer advances like cryopreservation, even fertility preservation in the cancer patients. That is cryopreservation of oocytes. That means we can preserve the oocyte, we can preserve our gametes, that is called as oocyte freezing or sperm freezing. So this freezing is done for fertility preservation also, like if at all the patient is undergoing some cancer treatment. So these cancer treatment drugs are actually very gonadotoxic. They radiation or chemotherapy, whatever it is very gonadotoxic. So in these patients, either in the females or in the males, we advise them for their gamete cryopreservation. So this is also a recent advance that has come up, and it's very with the advent of cryopreservation technique that I talked earlier also, the post thaw or post thaw recovery of these gametes, that is sperms and oocyte, has also improved after the advances in the cryopreservation techniques in our embryology lab. So these are the recent advances that I touched upon. Many other advances are occurring as IVF is a field where every day newer advances are happening. Yes, we will make you informed, we will keep you informed about whatever your advances that are coming, and that can help us in having in fighting this war against infertility, and having a win at the end, and having a successful pregnancy outcome, and having a healthy child. So this is all from my side. If at all any queries are there, if at all any questions are there from your side, we are welcome. We are happy to answer them. And of course, if at all any queries or physical consultation are required, helpline number are flashing on your screen, and we have physical consultation at Oasis Fertility Vakad and Kharadi branch. Thank you from my side. Thank you for your patient hearing. Thank you, dear friends. what are the new technologies in IVF? I already talked about this, that we have, for the patients with repeated implantation failure and repeated pregnancy loss, we have PGTA, where we can test the embryos. For the patients with poor ovarian reserve, we have ovarian rejuvenation techniques in the form of ovarian PRP, okay, or ovarian tissue activation is also coming up. Then for the patients with thin endometrium, there can be hysteroscopic PRP. IVM, I talked about IVM for the patients with, where they don't want ovarian stimulation or who are worried about ovarian stimulation. In those patients, we can think about IVM also, in vitro maturation, where we can retrieve the immature eggs and we can mature them in our embryology lab. That's called IVM. Other recent technologies like microtessay, then ICSI I have talked about, blast, that is day 5 embryo culture, and frozen embryo transfer. These are all the recent advances that have come up. Fertility preservations in the form of oocyte cryopreservation and sperm cryopreservation, even sperm ABD, where we can freeze even a single sperm, has also come up. What are the three main types of fertility treatments? Fertility treatment can actually depends upon what is the problem that the couple is coming to us with. Like, what is the problem with the couple, whether it is a male factor, whether the husband is having any problem like oligozoospermia, azoospermia, or if the wife is having, or the female partner is having any problem like in the form of PCOS, or poor ovarian reserve. So depending upon what is the problem and what at all the treatment they have taken till now, accordingly we plan the treatment. It can be in the form of, even if the couple has not undergone any treatment, then it can be in the form of ovulation study even. Okay, only follicular monitoring can help the couple to achieve pregnancy. Then it can be in the form of IUI, who have undergone ovulation study, or there is a problem, sexual dysfunction related problems are there, then IUI can help. Then in the patients with who have undergone IUI, or there is an obvious reason for infertility, like tubal blockage is there, or any other reason, obvious reason is there, then IVF needs to be advised. So this depend upon the couple that we are catering to, or the problem that the couple has, or whatever treatment that couple has taken earlier. So accordingly we actually make a plan for that couple, that what treatment that couple needs to take. What supplements increase fertility? This is a nice question actually. So everybody wants to know that what can we do as a couple to increase this fertility. So first I will stress upon is the lifestyle modifications. Today both the husband wife, they are working, they have working hours of around 10 hours. So stressful life is there, less sleep is there, sometimes there is more addiction, or maybe the timing of your having your food is not proper. So first and foremost is prioritizing your things, having timely food, fresh fruits, vegetables, and fresh fruits. They have natural antioxidants, sprouts, even they have folic acid. So these are the natural things which we can include in our life very easily. And of course, staying away from any type of addiction, even the passive addiction, or any type of addiction in the form of alcohol, smoking, hookah, anything which is there, we should refrain from any of these addictions, have the healthy lifestyle, or any junk food, any packed canned food should be avoided. And of course a healthy lifestyle, and of course maintaining the BMI by having a proper exercise, at least half an hour to 45 minutes of cardiorespiratory exercise, and at least 5 days in a week, at least that much exercise can, this exercise release good hormones in the form of endorphins in our body, and these good hormones can boost up our fertility. So yes, so exercise is also very important, and these lifestyle modifications are very, very important. We'll wait for 3-4 minutes for any questions are there, and then we will close the session. I think that's it from the question answer session also. So thank you, dear friends. I will close our session here, over here. Thank you for watching.